Caleb Alexander joined our faculty a couple of years ago. He was one of my first recruits. We brought him to Hopkins from the University of Chicago School of Medicine, where he was an associate professor. He joined us and the Department of Medicine. He actually sees patients. He's a practicing internist. But Caleb's background and specialty is in pharmacoepidemiology and the study of large databases of both mostly prescription drugs. And it was an area that I really felt was missing in the department. And he and Jody Siegel from the Department of Medicine have formed the Center on Drug Safety and Effectiveness, sorry. See, I get my stages mixed up. But which is really starting to take off and is getting a lot more recognition. And I'm sure within 5 years we're going to have a really thriving pharmacoepi group here at Hopkins to rival some of the groups around the country. So, Caleb.
Great, thank you. It's a privilege to have a chance to participate in this event on this beautiful day.
Maybe raining.
Could be. It certainly has been a lot lately. Terrific. And so, yeah, I'm really happy to be here and have a chance to talk with all of you about pharmacoepidemiology. And if you didn't guess, I'm here to talk about drugs and epi and not sex or disease. As you heard from David, and as many of you may know, pharmacoepidemiology is the study of the use and the safety and effectiveness of drugs in broad populations. And it's been terrific to come to Johns Hopkins. When I was considering a move, I spoke with Neil Poe, who at the time was at the Welch Center, I think maybe directing the Welch Center at the time, and he described Johns Hopkins as a vast sea of human capital, and that has really stuck with me. I mean, it is just bonkers. I can keep pinching myself, but it's just stunning. You can find an expert in any topic. And it's really been a terrific 2 years, and I'm especially grateful to David and to the department for the support, in part in launching the Center for Drug Safety and Effectiveness. I should also mention and give a shout out for at least two of the center scholars, Kevin Fain and Jingwen Tan, both of whom are in the room, and really trainees are one of our core missions and certainly make every day an exciting one. The center has a four-part mission: training, research, clinical care, and public service. We take the charge to help improve the care of patients in Johns Hopkins facilities seriously. I imagine many of you know Johns Hopkins ain't just a hospital. It's, I believe, 6 hospitals at last count, a 400-person physician group, 3 books of business and insurance that care for about 350,000 covered lives. And we have particularly strong linkages with the Department of Pharmacy. Ken Shermock is one of the associate directors of the center and sits within the Department of Pharmacy. And at the end of the day, as much as I love just as much as the next person trying to publish papers in JAMA and The Lancet and the like, we won't be successful if we haven't translated the new knowledge that we're generating into improved care for patients within Johns Hopkins medicine. We also take the service mission very seriously, and I'll mention 1 or 2 projects later that are directly engaged in public service, but naturally service is one of the 3 of the tripartite missions of the School of Public Health, and we once again want to be sure that we're directly helping to improve the safe and effective use of medicines in populations in the United States and indeed around the world. We have lots of active partnerships underway. One of the exciting things about pharmacoepidemiology is the number of stakeholders that it touches and the opportunities to work with many of these. And we have about 35 core faculty. And here I've provided just some examples of a select number of the partnerships that we have underway. These range from working with health insurers to estimate the cost of workplace injuries and prescription opioid use. We have a super cool project underway with a large pharmacy benefits manager. Very briefly, drug coupons, or as they're sometimes called in the industry, co-payment offset cards, are essentially means that manufacturers use to help reduce patients' exposure to out-of-pocket prescription costs. And they are increasingly important because of the increasing prominence of specialty and biologic drugs in clinical medicine. So these are drugs that routinely may cost more than $5,000 a month. And naturally, pharmacy benefits managers, groups like Express Scripts and CVS Caremark, use co-payments in part to help guide patients towards rational drug choices. So we have a very interesting project evaluating the impact of drug coupons on prescription use and expenditures, which is, there's very, very little empiric evidence about this. I'll skip down to the FDA. We just heard last week we were fortunate enough to be awarded Center of Excellence in Regulatory Science, or a CIRSE. This is a 2-year program and relationship between Johns Hopkins University, and it is university-wide, and the Food and Drug Administration. And this really builds upon a long history of work between faculty at Johns Hopkins and a lot of different touch points within the FDA. We, of course, will leverage our geographic proximity as well. The Department of Epidemiology has had a very active role in helping to direct and provide substance for the FDA Commissioner's Fellows Program. So we're really excited about the CIRSE. And last but not least, I mentioned consumer groups. We're just wrapping up a national survey that examines the general public's understanding of drug safety information. And this is with a consumer advocacy organization, and is a good example of our work directly in public service. So I'm going to spend the rest of my time on a specific content area, which is one of the 6 core foci of the center, and it's prescription drug abuse. And I'm not going to ask for a show of hands here, and I've already set you up well. And I know you're a smart group, and I also know you're really good test takers. So just ponder the fact. I mean, it's a stunning fact that, in fact, Vicodin, more hydrocodone is sold in the United States than any other drug. So we're talking the top-selling medicine by volume, by prescription, by number of prescriptions is Vicodin, and has been Vicodin, and will probably remain Vicodin, more than Viagra, more than Lipitor, more than Abilify and Nexium and the like. And so my question for you is, how did we get to a point where the United States accounts for 5% of the world's population and accounts for 80% of its prescription opioids? How did we get to a point where high school students report that prescription drugs are second only to marijuana in terms of ease of access? How did we get to a point where more people have died from prescription opioids than twice the total number of Americans that died in the Vietnam, Iraq, and Afghanistan wars combined? So this is the real dilemma, and I just want to share with you some of the facts and faces of this epidemic, as well as some of the work that we have underway to try to address it. And so I want to begin just with 3 faces from the epidemic. This is Benjamin Gupta. He was an MBA JD student at George Washington. He was found dead in his apartment. The medical examiner's inquest determined that he had died from a combination of OxyContin and alcohol. His blood alcohol level was actually only 0.03, so he didn't die from alcohol. He died from the combination, or from OxyContin. He had an extremely privileged upbringing. He was a staffer for Hillary Clinton. His parents are friends of the Clintons. Bill Clinton gave his eulogy. His parents had no knowledge that he had any access to OxyContin. He had never been prescribed this drug before. Steve Rumler, a very different situation. Steve injured his back, and back pain is the second most common reason people go to the doctor after upper respiratory infections. He injured his back. He was given opioids. He was given opioids for acute back pain. Acute back pain became chronic back pain. And ultimately, he developed a dependency on prescription opioids. He struggled with mental illness as well, and ultimately succumbed just 2 or 3 months after being discharged from a drug treatment facility. Somewhat presciently, before he died, he wrote of prescription opioids, "At first they were a lifeline, and now they are a noose around my neck." And last but not least, Emily Jackson. So Emily was 18 when her uncle gave her one OxyContin tablet. She swallowed it whole. She didn't crush it, she didn't crush it, smoke it, snort it. She wasn't using any other drugs, and she never woke up again. And so she died just 3 days before the start of her college. She had her whole life ahead of her. And so these are three of the faces that motivate this work, and three of the faces behind this epidemic. We've reached a number of very dubious milestones. I don't think you'll find a stakeholder that doesn't agree that this is, a top priority in terms of public health threats, and certainly within the world of pharmaceuticals. More people now die of poisonings and drug poisonings than die from motor vehicle accidents in this country. And of poisonings and of drug poisonings, opioids are the elephant in the room. So more than twice as many people die from prescription opioids as die from heroin and cocaine combined. And the deaths are just the tip of the iceberg. For every single death, there are hundreds more that are impacted, whether through treatment admissions or emergency department visits or abuse or dependence or non-medical use. And I would bet dollars to donuts that there's someone in this room that's been impacted directly by this epidemic. I gave a grand rounds at Anne Arundel Medical Center 2 or 3 months ago, and a nurse walked up to me afterwards and told me that her sister had died from a fentanyl patch. This wasn't an adverse drug event. Her sister had chronic opioid dependence for non-malignant pain, which is primarily the primary clinical syndrome that we're talking about, or the primary clinical use for many of the people that die. I should mention more than 9 in 10 decedents have seen a doctor within the previous month and have received prescriptions for prescription opioids. So don't believe that this is someone going down to the street corner alone, and that these medicines aren't coming from contact with healthcare professionals. This is a graphic of sales, deaths, and treatment admissions, and they're, on the x-axis is 1999 to 2010, and you have sales in green and deaths in purple and treatment admissions in yellow. And you don't have to have a PhD in biostatistics or epidemiology, although I know many of you do, to see that there's something going on here. And, I think what this suggests is that at least under historical and current regulatory and market conditions, we shouldn't expect the morbidity and mortality from this epidemic to decline until sales of opioids decline as well. So I want to briefly mention 5 factors that complicate this situation. And I would argue that this is one of the most complex issues in pharmaceutical policy that we've seen in the past few decades. And there are a few reasons for this. The first is that historically, we've done a poor job treating pain. And we conducted a study, I don't include it in any of the slide deck here, but we conducted a study using nationally representative data to look at the treatment of pain over a decade. And what we found was that essentially the proportion of patients with a primary symptom or diagnosis of pain that receive an analgesic, in fact, hasn't changed over the past decade. It's about 50%. But what we do document is that in addition to large increases in opioid use, we see declines or flat levels of non-opioid use. Thus, increases in opioid use have not been accompanied by large increases in the use of non-opioid analgesics. The second issue is that these drugs are addictive. And, when I was a resident at the University of Pennsylvania, we were taught that if a patient had true organic pain, you didn't have to worry about their becoming addicted to these drugs. We were taught that if they have true pain, that the true pain soaks up the euphoria of the opioids. And this is bunk. I mean, if I showed you a molecular structure of heroin and OxyContin, you better believe they're much more similar than they are different. And I think that the medical community has underappreciated the addictive nature of these drugs. And interest permitting, I'm happy to talk a bit more about this in any Q&A. The third issue is externalities and the fact that even well-intentioned doctors treating well-deserving patients in pain may be contributing to the epidemic. Sue Baker, who's a pioneer in injury prevention and from the school, has a great anecdote about going and getting a tooth pulled and getting a prescription for 80 Vicodin when she needed 5. And the fact of the matter is that if you look at where non-medical use is coming from, about a fifth of patients report that they got their drugs from a single doctor or other licensed prescriber. And of the 50% that report that they got it from a friend or family, those friend and family in turn, in 80% of the cases, report that they got these drugs from a single doctor. So this isn't just about doctor shoppers and people that are seeing 10 different doctors and 5 different clinics and cash paying for drugs and the like. Diversion happens all along the supply chain, which is another complicating factor. And last but not least is the number of stakeholders involved. I mean, you better believe that the president of the American Medical Association may have different perspectives on this issue than the CEO of Purdue Pharma. And, this is a $9 or $10 billion a year industry. And so, as is often the case in pharmaceutical policy, where you stand on these issues depends upon where you sit. We're doing work to evaluate prescription drug monitoring programs. We were fortunate to receive an award from the Robert Wood Johnson Foundation. Prescription drug monitoring programs are some of the principal means that states are using to address this epidemic, and these essentially collect and analyze and report information on prescribing and utilization of opioids. The main goal of these PDMPs is to reduce prescription drug abuse and diversion. And what we've licensed is a mammoth data set. So it's 8 years of longitudinal all-payer claims data for pharmacy claims for 50 million Americans. So essentially, we have Medicaid, Medicare, cash pay, and commercial insurance. And for 50 million Americans, all of whom filled at least 2 or more prescriptions for an opioid in at least 1 year of observation, we have the universe of their prescriptions. So it blew up several of our computers before we actually figured to get to biostatistics for their computational core where the data sits. It's more than 5.2 billion transactions. It's more than a terabyte of data. And the beauty of these is that they're individual level data so that they'll allow for us to really examine, and that every prescription is linked to a specific prescriber and a specific pharmacy. We're in the very, very, very early stages. These data we just got up and running about 2 or 3 weeks ago, and this is just one plot, one example that we generated last week. So these are smooth data. On the x-axis, you have from 2006 to 2014, and this is in Florida. And what it depicts is quantiles of prescribers in Florida from 2006 to 2014 based on the average prescribed opioid daily dose during a given month. And the y-axis ranges from 0 to 300 and depicts morphine equivalence, which is a standardized method for examining opioid strength. Florida's the epicenter of this epidemic, and this is where we're starting to focus. And what these data suggest is that the tremendous increases in opioid sales that have already been characterized by others in Florida were driven by a small proportion of prescribers whose daily doses increased dramatically during the run-up to the implementation of the PDMP. So you see the highest quintile is the 95th percentile of doctors, where you see this very large peak where they're prescribing on average, their average daily dose for a patient is almost at 200 milligrams of morphine, when many professionals will say you shouldn't exceed 1 or 120 in any circumstances. So we have lots of different outcomes that we'll examine and lots of different ways that, we're interested not only in the aggregate effect of the prescription monitoring programs, but we want to look at specific subsets of patients and prescribers and pharmacies where there's evidence of particularly high-risk use. We are delighted in 2 weeks, May 13th, we will, that is the Center for Drug Safety and Effectiveness, in concert with our partners in injury prevention and the Office of External Affairs at the school, are delighted for this, what we believe will be a highly publicized town hall event, Tuesday, May 13th. We already have about 250 registrants. By all means, please register now if you're interested. This event will occur back-to-back with an invitation-only closed-door session where we will gather leadership from a variety of stakeholders to identify promising policy and practice interventions to reduce prescription drug abuse, as well as to identify important research gaps and next steps. I know what all of you are wondering, and the answer is I have no idea whether President Clinton will join us, but he was present at the launch of the Clinton Foundation's campaign to tackle this problem, and this is the one-year anniversary. But whether or not he's present, I'm confident that this is going to be a very compelling town hall event the afternoon of the 13th. I like to end with this, which has nothing to do with prescription drugs, not because it has nothing to do with it, but because it really demonstrates a true victory for the public health community. And what it depicts is, over the course of a century, remarkable reductions in deaths from motor vehicle accidents, all the while there were huge increases in the number of vehicle miles traveled during this period. So I think that I think that we are on the cusp of turning the tide on the morbidity and mortality from prescription drug abuse. I focused on opioids. We can talk about non-opioids, but I focused on opioids, I hope, for a reason that's clear to you. And I really do think that we're at a pivotal point and an inflection point as a community and as a country in helping to reduce the morbidity and mortality associated with this. So once again, I really appreciate the chance to participate in this event and look forward to any comments or questions that you have.
Thank you, Caleb. That was it's fascinating. And it's really interesting because in my world, there's a lot of prescription drugs show up right on the street. There's a lot of value. So the faces you didn't show are kind of street-level drug users who, when they have a hard time getting heroin, they get prescription drugs. So will you talk a little bit about that, because it's two very separate worlds that collide around this drug abuse.
Yeah, thank you. And the question was about heroin use and prescription drug use, and we're really interested in this issue, and it's one that I think Philip Seymour Hoffman's death sensitized people to. And following his death, there were several pieces in national media talking about the degree to which individuals substitute between heroin and prescription opioids. And we want to examine this empirically. So we actually have 5-digit zip codes for every prescription transaction. And so one of the things we want to do is to use our data and look and build models and look at the substitutability and interrelationship of prescription opioid sales and availability and the use of illicit opioids like heroin. I would also just say that I wish I had the slide that showed their molecular structure, but, heroin was legal and a prescription drug 100 years ago. And so I really think that it's remarkable that as a society, we have something that's as stigmatized and penalized and criminalized as heroin on the one hand, and then and yet use enough prescription opioids that we could supply every adult in the United States a 4-week supply of continuous Vicodin. And yet prescription opioids are in such a different category in many ways. So I appreciate the question, and we do want to do empiric work to help examine some elements of this.
In most countries, in most countries of the world, you cannot advertise prescription drugs in the mass media. Any hope for that in this country?
Well, I wouldn't hold your breath. So we have an award from the NHLBI to look at the impact of direct-to-consumer advertising on drug utilization and expenditures. And, it's a highly contentious area. It's a unique, I don't know whether I should call it an anachronism of our regulatory climate. But I wouldn't hold your breath is the answer. You're right. I do think it's important to mention that DTCA or direct-to-consumer is only about 15% of all marketing and promotion, and it's also highly concentrated, so that I think 2/3 of DTCA takes place for about 20 or 25 drugs. But with that said, I think a lot of people in public health and clinical medicine rightly wonder just what the heck is going on. When you come home and see ads and see the ways that prescription drugs are advertised. It's not just that, sertraline is advertised on TV, but it's the way that the commercial is framed and the like. Great. Well, thank you so much.
Well, that actually concludes the formal part of the program. I think you'll agree with me that the future of the department should be very bright given these the performance of these 4 faculty members. Please join me in thanking them for their time today. And we will now begin the second component, which is actually to meet up with each other. If you go out of the hall, just to the left, there's a huge set of monitors, the Wall of Wonder, and we will have a reception out there, and I think you'll have an opportunity now to really collar the 4 speakers. So thank you for coming, and we really appreciate seeing many of you.